FGF23 has many other roles, and so we should keep this in mind while we treat our patients, especially with this new therapy, because there is many off-target effects that we need to look at, and also some effects that are not cured probably by the therapy, that are maybe due to the FEX mutation and not to the FGF23 effect. And so if we look at what are the disorders that will lead to an elevated FGF23 production and then low phosphate, high urinary phosphate, and rickets in children, we do have some disorders that are genetic disorder, hereditary phosphate wasting disorders, where FGF23 is either produced in excess or is not cleaved because of a mutation on the cleavage site on the FGF23 molecule. So if you have a mutation in either of these molecules, in FEX, in DMP1, ENPP1, or FGF23, you have a form of rickets with an increased level of circulating FGF23 and then rickets. But there are also other causes of elevated FGF23 that are due to an uncontrolled production by proliferating cells. We could call it like that. When you have, for example, the fibrous dysplasia cells, when you have a big volume of the fibrous dysplasia, these cells can produce FGF23 and then end up to give low phosphate and rickets. The extended cutaneous nevus also may produce FGF23, or the mesenchymal tumors that are known as TIO, tumor-induced osteomalacia. These are small tumors of the skin or the bone that may produce very large quantities of FGF23 and give also low phosphate and rickets. But those are, I would say, more frequent in adolescents and adults, and these are really more adults disorder. TIO, or FGF23 production by tumors like hepatoblastoma or carcinoma, are phenotypes that are usually more striking, more severe, with very low phosphate and fractures, asthenia. I mean, very phenotypes. I mean, you cannot miss it. So I will not spend much time on this, and then we'll go much on the clinical phenotype of the patient, and so I will talk about how they are and how they evolve when they are on the conventional therapy. So because of this mechanism of the disease, that is that they have phosphate wasting and lack of 125 synthesis, the obvious therapy was to give them active vitamin D analog and phosphate supplements. But you know very well the difficulties of this treatment when you have to balance every time you see the patient because you want to give them as much as possible to cure or to heal the rickets, but you have to deal with hypercalciuria, nephrocalcinosis, lithiasis with the vitamin D analogs, or even hypercalcemia in very few patients. And with the phosphate supplements, then you have to deal with the risk of hyperparathyroidism and also nephrocalcinosis. So it's really a balance between these two therapies, and something that is really not easy to deal with. Hopefully the treatment does something on the clinical phenotype of the patient so that it heals the rickets. And so the skeletal consequences of the FEX mutation, or of the of elevated FGF23 levels, are osteomalacia and odontomalacia. The rickets and the impaired growth. And so I think there will be a talk about growth later. And so these skeletal consequences, they are due probably to this elevated circulating FGF23 level, and basically it is the hypophosphatemia that is the cause of odontomalacia and osteomalacia. If you give phosphate to any rickets, you will cure the rickets. So hypophosphatemia is certainly the cause of rickets. So this is this young girl at the age of 2 years at the time of diagnosis. So you recognize this very typical waddling gait that, and where she walks with the feet that are spread. Okay. And then, so when we start the treatment, after so it takes really a lot of time to heal. And after 1 year, there is still this bowing of the legs. And the gait is, but the gait seems better already after 1 year. After 2 years, you have the legs almost straight, I would say. But if you do an X-ray, it looks worse than that. After 4 years, here you cannot say that she has rickets when you look at her. So this is the kind of patient you would like to have, every day. The one that takes the medication nicely. And so, but this is not the majority of patients. And if we look at the number of patients that do have leg bowing over time. So at the time of diagnosis, not all the patients do have leg bowing. Some do have straight legs, but still, when they about half of the patients still keep with deformed legs during therapy. So the treatment is not that good for all the patients. When we have done the treatment for the rickets, what is the result, and do we need to operate these patients? So there is on this picture, so I've put some patients to see. So basically, these 3 patients who would not go to surgery. They have nice legs. And although this one has a little bit bowed tibia, and when he's walking, you can see that there is something not completely straight. But these 3 will definitely go through surgery. Otherwise, they will have rheumatologic complication soon.